5 seconds. 5, 4, 3, 2, 1. Sir, we are live now.
Okay. So good evening, everyone. And this is the sixth fellowship lecture that I'm taking today. And I'm going to talk to you about facial injuries today. And I'm going to divide my talk into two parts. Yeah. First is general concepts of acute facial injuries, because you're going to see injuries to the facies in two different scenarios. One, when you have an acute injury, how to recognize and how to treat it, and a little bit theory about classifications and what causes problems. Some of the injuries we have already gone through in various regional talks like elbow, ankle, distal radius. Some of them you might find there is a little repetition, but it's good to have a revision. So with that little preamble, let me start. And why is it important? Because very often facial injuries are missed. Okay, there is a very high incidence of growth disturbance if you miss a facial injury, and that can get you a really bad reputation. Bony bridging or a facial bar may be a result of a direct facial trauma, or because your anatomic reduction of the facial injury was not done, or because of a badly done implantation. Let's look at some classifications, and I'll give you a very good historic perspective and some background over it. So this is, look at the year 1898. This was Poland's original classification of facial injury. And in that, you can see that the facial injury, which is seen here, Poland has classified into 4 types: type 1, type 2, type 3, and type 4. And pretty much the same classification or the same diagrams you will see in Salter-Harris, right? Type 1 going across the facies, type 2 with a metaphyseal fragment, type 3 which is intra-articular and going through the metaphysis. Now, Bergenfield in 1933 gave a more refined classification. Okay, so this was 1933. Bergenfield has given us 6 types, right? And just look at the classification. Type 1 is transfacial, type 2 is with a very small Thurston Holland fragment, metaphyseal piece. Type 3 is with a large metaphyseal piece. Okay. Type 3 is today's Salter-Harris type 2. Type 4 is where today's type 3. Type 5 is going across, and type 6 is a compression injury. But the majority of the injuries were type 2 and type 3 in Bergenfield, 31% and 50%. So 80% injury was type 2. Yeah. Can you see this classification? It is very, very similar to what has been published today and what we follow, the Salter and Harris, with a small little modification here and there. But then why didn't Bergenfield get the recognition? Simple reason, all his work was in German. Okay, so if you go to some other language and some other country, this is what should have become the standard classification. But again, English literature, unless some Englishman copies it and puts it as its own, it doesn't come into popular literature. Most of us probably study in English language. So Italian, French, German, most of these people who have done very good work, very significant work, comes out in the English world very much later. For example, all the work done by Elizarov came into English literature only when Drawer Pelle went and visited and started publishing in English. And he became the most popular person. Okay, but the work was all Elizarov work. Catani's work, which was in Italian. The brachial plexus work, okay, which is again done by the French people and the Italian people. Unless it comes in popular English literature, it doesn't gain recognition. So this was the sad part of the story. And as I said, 80% were the type 2 so-called Salter and Harris. 1936, Aitken came up with his classification, which had only 3 types. One type 1, 2, and 3, which was actually Salter 2, Salter 3, and Salter 4, which is today's classification. These were the workhorse. Common injuries were only these 3. Okay, and this became a standard. And most of the people use this classification for nearly 25 years. Okay, and all had been reported by Bergenfield much earlier than him. In 1957, Johnson and Fall described what is now known as the triplane fracture. Okay, they described this three-plane injury in the ankle fractures, and this was Salter 2, okay, in the lateral, Salter 1 on AP, and actually it was a Salter 4 injury. Okay, so it's a 2 on AP, 3 on lateral, type uh, 1 on, type Salter 4, which is actually misinterpreted as Salter 2 and Salter 3. Okay, so that is the peculiarity 2, 3, 4. Okay, now if you look at the paper in 1963 by Salter and Harris, this is what gave us our 4 types. Now this was Salter 1, which Poland had already described in 1898. Then you had the Aitken classification, which had type 2, type 3, type 4. And then you had the compression injury. So this is the current 1963 Salter and Harris classification that all of us use. Type 1 goes through the physis, type 2 with a metaphyseal fragment which is large, type 3 is intraarticular, type 4 is metaphysis and epiphysis and growth plate, and type 5 is a compression injury. And in 1969, Mercer rank added the perichondrial injury, that is a peripheral injury because of a direct blow to the periosteum or the perichondrium at the periphery. This is very difficult to diagnose initially, clinically. Okay, and it may be seen on MRI, and it's usually a retrospective diagnosis. And the latest classification of facial injury is by Peterson, that is 1994. And what he has described is a progression from the metaphysis to the epiphysis. So type 1 in Peterson is a comminuted metaphyseal fracture with some lines going into the growth plate. Type 2 is a type 2, which is also Salter Harris 2. Type 3 is a transfacial, which is Salter Harris 1. Type 4 of Peterson is a type 3 of Salter and Harris. Type 5 of Peterson is a type 4 of Salter Harris. And type 6 of Peterson is a compound injury with missing physis. So what he said was, from the metaphysis, complex fracture, simpler, then transfacial, then intraarticular, then going across both, and then last is missing. So he said that in continuity, the anatomic classification, it's a facial injury in continuum, and potential for growth arrest increases from type 1 to type 6. Okay, and that is why the complication rate is highest in type 6. Peterson classification is the latest, but only rarely do we use it. We still follow most of the time Salter and Harris. And in the type 1 of Peterson, he gave the types of comminution of the metaphysis. Okay, single fragment, multiple fragment, etc., A, B, C, D. And in the type 2, again, he gave subtypes A, B, C, depending on how big the metaphyseal fragment is. Okay, a very large, a small, or a very small. Okay, because that affects stability and type of fixation. But more than only the injury to the physis, everybody should realize a couple of things. One is that the blood supply is also very important. And look at the cellularity of the physis. The physeal plate has got a zone of resting cartilage, which is on the epiphyseal side, and a zone of young mature cartilage, which is ossifying, which is on the metaphyseal side. Okay, and the blood supply comes from either side. One is from the epiphysis, one is from the metaphysis, the loops here, and one is from the perichondrium. So it's not only injury to the cells, it's also a vascular injury which goes across the blood supply. That is also very important. So if you look at type 1, the type 1 injury actually is running through the zone of young, ossified cartilage. Okay, it is away from resting cells, and it really does not cause much of vascular damage. The epiphyseal vessels to the resting cartilage is intact. The metaphyseal circulation is intact. There may be some injury to the perichondrial region, but most of the perichondrial injury is also well vascularized. So type 1 injury actually doesn't cause much of growth arrest. If you look at, that is why if you see transfacial separations like this, okay, in humerus, you will see that they heal very well and remodel beautifully. If you look at type 2 injury, the type 2 injury is a fracture going through again the zone of early calcification, and then it goes into the metaphyseal region. So the metaphyseal blood flow is disrupted, but the epiphyseal blood flow is okay. Again, resting cartilage gets good blood supply. So the chances marginally increase of growth arrest, but lesser than type 3. This is the common type, a type 2. Now look at type 3. Type 3, what is happening is your fracture line goes intra-articular. So you are losing the cellularity and blood supply of the resting cartilage, which is the young immature cartilage, which is going to contribute largely to growth. So Salter 3 has higher chance of growth arrest, where blood supply to epiphysis is gone and cellularity is fractured where there is resting cartilage. And then it goes across through the mature cartilage. Okay, so this is important to know. Type 4 is the worst, obviously, because you have intraarticular and you are losing blood supply from both sides, metaphysis and epiphysis, as well as resting cartilage is injured. So type 4 is the worst for growth arrest, right? Which you know because of our ankle talk that this is a crushing injury. Type 5 again is a bad injury because it is not seen primarily and it's a crushing injury, a compression injury. So a fall from a height causing compression injury or a perichondrial ring injury which disrupts the blood supply as well as crushes the cartilage which is in the resting zone is a bad injury which can cause a growth arrest. And again, it's not a primarily diagnosed injury on X-ray. It will always be seen later. So these are the deformities you will see. In fact, a tibia vara or a Blount's disease is considered to be a type 5 Salter injury because of obesity and genetic predisposition, where you have crushing of cartilage because of eccentric weight bearing on the heavy child in a black, genetically, racially black patient. Type 6, again, as I said, these are peripheral injuries. Apophyseal injury because of avulsion or iatrogenic injury when you are passing an elastic nail. And I'll come to that. So these are type 6 peripheral injuries or something like a apophyseal injury because of a avulsion of the tibial tuberosity. Now, these are type 6 injuries. Clinically, always when you are suspecting a physeal injury, you must palpate the physis. There will be pain, there will be local tenderness. If it's intra-articular, you will get hemarthrosis. Sometimes you can feel a palpable gap and there may be crepitus. You'll always look for neurovascular problems. On a plain X-ray, look for widening of the physeal gap. When in doubt, take stress X-rays or comparative X-rays or oblique X-rays. That will give you clues. Stress X-rays are painful and I won't recommend that you do them in the casualty. They're just one of the things that can be done. And you can do arthrograms, especially around the elbow. So this is an 11-month-old child fall from cot. Again, you can see just a small metaphyseal crack there. You don't know. There's a large soft tissue swelling. Oblique X-ray gives you a better idea to the extent of injury, lateral condyle. Comparative X-ray shows you that there is displacement and arthrogram shows you the extent of the intra-articular component. Okay, so these are additional imaging modalities that you must know. Hello, you can hear me?
Yes, yes.
Yes, sir.
Okay.
Yes, sir, we
So
can
this
hear you,
is-
but the recording is stopped now, sir.
Okay, something, I don't know,
I think
recording
just
का
now
क्या
they
हो गया?
started the recording.
Hello? Maharshi? Hello? Maharshi? Ashok? Neeraj, who's there? Who's there from OrthoTV? The recording has got stopped.
No one online from host community.
Okay, I'll have to just check with. Give me a moment, otherwise later on you will not get the recording. Let me call up Ashok.
Sir, you are the host. Actually, there will be an option there to start the recording again. Sir, actually there is an option there, record म्हणून.
Sir must be busy calling up Ashok Shah.
Ashok is here. Can you hear me?
Yeah, I can hear you, sir.
Yeah. Can all the delegates can hear me, no?
Yeah.
Yeah,
Yes,
everyone.
sir.
Okay. So can I resume?
You can
the
carry
talk?
on, sir. Carry on.
Okay, recording हो रहा है ना?
Yes, yes.
All right. So, okay. So this is an MRI. I have already showed you lateral condyle MRI, how it looks. And treatment issues, when you have an intra-articular fracture, especially when the growth remaining is less, it's important to have a perfect reduction so that you minimize deformity and get a perfect articular alignment and prevent further growth plate damage and get a good function. So let's go according to the Salter classification or the Peterson. Undisplaced fractures, metaphyseal fractures can just be immobilized in a plaster with a 3-point molding and tighten up the intact periosteal hinge so that there is no displacement. You always take an X-ray after 1 week to make sure that there has been no displacement. Usually in 3 to 6 weeks, all injuries will heal up. Cast is removed and active range of motion, but always follow them for 1 year. If a growth arrest has to happen, you will see the Harris growth arrest lines. And if they are converging, there will be a bar. So type 1 Peterson, as we said, comminution in the metaphysis, which is going to the epiphysis, close reduction, cast for 4 to 6 weeks, and follow up for growth arrest. Make sure that there is no growth arrest. Peterson type 2 is the same as Salter 2. Depending on the size of the metaphyseal fragment, after your reduction, you may consider stabilization. Remember, when you are reducing this fracture, your treatment should involve no shearing force. Always give longitudinal traction and exaggerate the deformity first. Never attempt reduction of a fascial injury without anesthesia because you'll end up causing crushing of the cartilage. Aspirate the joint if it is swollen so that it relaxes and allows you better traction. So general anesthesia, always aspiration before manipulation. The first maneuver should increase the deformity and then give longitudinal traction and then tilt it over. So the sequence of events is to pull, tip, and then close the separation. The maneuver should be 90% traction and 10% leverage in fascial injuries so that you don't cause further crushing of cartilage. We have discussed this point earlier. How many attempts at trying to reduce a fascial injury? We know that trying to do too many attempts will cause more damage and leaving them will be okay. Pinning, we have discussed the pinning issues and we have shown you already with these slides that pins really don't cross growth arrest unless you are doing multiple attempts or putting the pins too long and creating cross union. When you are passing the pins, avoid the perichondrial ring, keep them as longitudinal as possible and remove them as early as possible. I have showed you the technique of doing an intrafocal pinning where you are not crossing the physis at all and using the pin as a dorsal buttress, especially in Salter 2 injuries. If you are passing screws, make sure they are from metaphysis to metaphysis or epiphysis to epiphysis. Don't try to cross the screw across the epiphysis. Okay? So always try to do cannulated screws over wires and make sure that you can do it when you have a large metaphyseal fragment so that you get better stability and supplement it with a cast. Peterson type 3 is a transfascial separation, which is Salter 1, reduce as much as possible without any kind of a shearing impact and accept an imperfect reduction rather than hazarding any kind of open reduction. Okay, growth arrest is larger if you try to do forceful maneuvering or late manipulation or implants. It's okay to have an imperfect reduction which will remodel very fast. Type 3 injuries can get growth arrest and may require treatment in addition. Peterson 3 or Salter 4 is where you have to look for intra-articular injury. So subtle injuries like this have to be looked for. And then, as I said, you must have smooth pins across the physis and compression screws across epiphyseal so that the articular congruity is well maintained. Type 4 Peterson, also type 5 will need open reduction because you need to restore articular congruity as well as fascial congruity. Okay, so I have showed you this in ankle injuries. You can't, if you do a closed method, you have to make sure that there is no interposition and an arthrogram to confirm articular congruity. Okay, so Peterson 4 injury, intrafascial screws across the physis, anteroposterior or lateral, depending on the situation. Examples again, use cannulated screws and get accurate open reduction. When there is a missing physis, growth arrest is assured, and this is a compound fracture which will require appropriate treatment with soft tissue procedures, and then you have to manage the growth arrest with more procedures later on. The prognosis of any fascial injury depends on the severity, whether it was a low energy injury or a high energy injury. What is the age of your patient? How much growth is remaining? How much remodeling potential is there? Second, the site of injury. Is it a fast growing physis? Is it a slow growing physis? And Peterson classification, which tells you the higher the grade of Peterson, the more chance of growth arrest. So again, never miss a fascial injury, especially in polytrauma. When your patient has got polytrauma or is unresponsive, remember to palpate the physis. Around the knee, remember that the ligaments are stronger than the growth plate. If you see or feel instability, you are more likely to have a fascial avulsion or a fascial injury rather than an ACL tear. Okay? So recognize the injury, achieve the best anatomic reduction with minimal attempts which least force, fix only when must, and follow the principles of fixation. Always explain prognosis in a child who has a fascial injury. Regarding growth arrest, keep a close follow-up at least for a year. Diagnose a growth arrest early and treat the complications so that you don't end up with bad problems. Right? So that is the talk on acute fascial injuries. So I'll take a short breather here, and if you want to ask any questions regarding acute fascial injuries, we'll answer them now.
May I ask?
Yes, please.
In grade 1 Salter Harris, you said in treatment plan, close reduction and casting and
Yes.
frequent follow-ups to see
Yes.
or to check that if there is growth arrest.
Yes.
What is in our hands to prevent that growth arrest, or if the growth arrest is happening, what will be the treatment plan or change in the modality or the any information regarding that to the parents? What we can
Correct.
do,
So,
what we are supposed to do.
Yeah. So there are two common questions. One is that how does one recognize a type 5 injury where you don't see anything on X-ray, or how to recognize a subtle type 1 injury? And if it is a displaced type 1, how to treat it? Right, Nitin sir, that I think is
Yes,
the crux of the question.
Yes.
So most of the times, as I said, the type 1 injury passes through not the resting cartilage, but from the early calcified cartilage. So theoretically, the chances of growth arrest are not very high, but a complete separation with displacement has a higher chance, where a reduction might be needed. Whenever you are trying to do a reduction for a type 1 injury, try not to do too many forceful attempts. If you are going to reposition the physis under full anesthesia, like I said, make sure, I'll just put on my camera because I think my camera is off. Okay. So what I was saying is, if there is a transfacial separation, distract it first. Aspiration of the hematoma or the joint hematoma, distract it first and then tip it over to get as much as possible reduction, but don't aim for a shearing forceful reduction in an attempt to get a good looking X-ray. It might be better to accept an incomplete or a partial reduction which is got by least force. So what is in our hand was your question. In our hand is a gentle close reduction with aspiration of hematoma under general anesthesia, aspiration of the hematoma and a well molded cast, and not too much of attention to an exact X-ray, and trying to avoid too much attempts at trying to fix this fracture. It is
Okay, but
easier for the fracture to remodel. But like any facial injury, always you will counsel parents. See, like
Hmm.
I have told you during the ankle injury, my counseling method is that you tell them that your child has suffered a severe injury to the root or the मूळ, if it is in Marathi, हाडाच्या मुळाला इंजुरी झाली आहे जिथून हाड वाढतं. Okay, it is at the
Yes.
root of the bone from where your bone grows. If we position it perfectly and accurately, the chances of creating a growth arrest are minimal. So we will attempt that and do it gently under anesthesia. We can't do it in the OPD. After that, the chance is reduced, but it is not eliminated. So you must come to me every 3 months for an X-ray. And if I find there is a growth arrest, we will need additional procedures to correct the situation, depending on what kind of growth arrest happens. We'll talk about it in the next talk. And second is again a perichondrial injury. So whenever you have, most of the times, I'll show you an example in the next talk, a blunt injury to the lower end of the femur, upper end of tibia, which is peripheral. Always warn the parents, if there is tenderness along the physis, that he has suffered an injury to the growing end of the bone. He doesn't need active treatment right now, but we need to observing for consequences of the same. If nothing happens for a year, nothing will be needed. If something happens, we'll treat it according to what happens. But make them aware that injury to the mid shaft is different from injury to the growing end, and do it upfront. Second thing is, if you are in an urban situation, like I am working in Pune in Sancheti, and my patient, if it is affording, I will ask him them to get an MRI. Okay, because that will document the lesion for me on day one. In a peripheral area, MRI may not be possible, and MRI may require sedation or anesthesia. So I'm not saying that go and diagnose every child with an MRI. But even on an X-ray, palpate the physis, and if it is tender, warn them that this can happen. If the child wants more information, parents are IT professionals, and you want to show them, you can get an MRI, prove the diagnosis, and show them, see, देखो इधर लगा है, अभी प्लास्टर लगाना है, 3 हफ्ते के बाद वो ठीक हो जाएगा. 90% कुछ नहीं होगा, लेकिन कुछ होगा तो ये इंजरी को मॉनिटर करना पड़ेगा. आगे क्या होगा वो देखेंगे, उसके हिसाब से ट्रीटमेंट. गोपेंद्र.
Okay.
Yes, sir. Sir, actually, it's not a question. It's a small mnemonic to remember this Salter. यानी जो जूनियर लोग हैं उनके लिए कुछ काम आ सकता है ये.
हाँ.
तो सर Salter में ऐसा सर कि जो अल्फाबेट्स हैं SALTER.
Yeah. That has been published by many people. रैंक के किताब में है वो. मर्सर रैंक के किताब में SALTER.
Yes, sir. It's very beautiful. Means it will be very good.
Yeah, you can talk about it. No problem. People can read about it. No problem.
Yes, sir. So S is straight. Type 1 S is straight. Type 2 is Salter का A आ जाएगा. तो A is above fracture line. Means in fracture line above in metaphysis. Type 3 is SAL. L. So L is low. Low means its fracture line is in epiphysis. Then SALT. T is type 4. Type 4 is T means total. It's in metaphysis and epiphysis both. And type 5 is E का मेरे को ख्याल नहीं है सर. And type 6 is R. Salter का R is 6. That is rank type. So it's good for juniors.
Yeah. So as you see more and more, you will not need mnemonics. When you look at the X-ray, you will find out what type it is. See, the common X-ray findings are always Salter 2, which is not very difficult to diagnose. Okay, Salter 2 is when you see a Thurston Holland fragment in the metaphysis. Okay, simple.
Yes,
now, if you see intra-articular, it is 3. If you see intra and transphysial, it is 4.
Yes.
2 is the commonest.
Yes,
Okay,
sir.
that's why Atkins classification was very popular for 25 years. 3 basic types. If you see metaphyseal fragment, Thurston Holland, it is type 2. Okay. If
Yes,
it
sir.
is going across the physis into the joint, it is 4. ठीक है? If there is no metaphyseal fragment, it is only intra-articular, it is 3. 5 you don't see on X-ray, and 1 is transfacial. Sometimes you see, sometimes you don't see, depends on displacement.
Yes, sir.
Okay?
Yes,
ये
thank you.
कंफ्यूजन में हर बार R का मतलब क्या है, T का मतलब क्या है, A का मतलब क्या है, वो
हाँ,
एग्जाम
that's
का
what
आंसर
we-
लिखने के लिए, डायग्राम निकालने के लिए अच्छा है.
हाँ.
प्रैक्टिस में you look at the X-ray, it's quite easy. Rohit, yes?
Sir, type 6, that is avulsion types.
Yeah.
What is the treatment? That is that same
Yeah.
K-wires or some.
No, see, avulsion fractures are there, no? They are ligamentous injuries. Okay?
Yes.
And if they are involving the perichondrial ring, for stability, you will need to restore your bone fragment where it belongs. But you can assure them that this is going to end up with a growth arrest.
Okay.
So your treatment is going to be a screw fixation,
Okay.
which may end up in a growth arrest because of the injury itself. But if it's an avulsion fracture, no, you need to put it back and have compression.
Okay. Right.
Okay, so that is especially the tibial apophysis.
Yes.
Tibial apophysis or lateral collateral avulsion, you will have to repose it for ligamentous tension, the patellar tendon or the lateral collateral.
PCL
And because
avulsion.
of the injury itself, it's going to cause a peripheral growth arrest. If it doesn't, you are lucky.
So this type
Sir,
6
but
is
it
what
is the avulsion
Peterson
injury,
type
can we
6
put
or
the-
Salter Harris type 6, we should say. What
Pardon
we
me,
should
yeah.
say.
Perichondrial injury with a bone piece which has come out, if it is a peripheral injury.
Okay.
Yeah. Karthik, you wanted to say something?
Sir, it's an avulsion injury. If it is not big in a pediatrics, how to put the screws, sir, for compression? And like
No,
where
so-
to put the screws, sir? Like through the physis, it is coming out, no, perichondrial.
That's what I'm saying, that you will end up with a growth arrest in any case because of the injury. So depending on the size of the fragment, either a 4 mm or a 2.5 mm screw, or if it is even smaller than that, to restore the tension, you can take transosseous sutures or use a minimitic anchor. It all depends. See, an avulsion injury, last week I did an ACL avulsion. So I had to use a very small Arthrex 2.7 mm Herbert screw. So there are various small implants available now in pediatric orthopedics. Okay.
So, Sandeep sir,
Yeah. Yes.
with this Salter's classification, Milch 1 becomes type 4.
Milch
lateral
1
pneumatic
injury
contact.
is type 4. Yes, you are right.
And
If it
2A
is,
is
like
2.
I said, see, when you are talking of Milch, no, it is going from metaphysis into the epiphysis. But we don't know whether the fracture is complete or incomplete unless you do arthrogram.
Right.
So the Milch classification was not
Not that
depending on
valid.
whether it is complete. It depended on elbow stability. I told you in the lecture on lateral condyle. If the exit of the fracture line is medial to the medial crista of the trochlea, the entire fragment and the elbow dislocates.
Type 2. Milch
Yeah,
type 2
and type
original.
1 is, it is lateral to that. The fragment may rotate, but the elbow is stable. So that was the Milch classification. Whereas the other types tell us about displacement. How much of the lateral condyle is displaced? Now the good part is it's intra-articular injury, it's intrafascial injury. The good part of lateral condyle and elbow is that you know that elbow doesn't grow much. 90% growth is in the proximal humerus. So it's more to be treated like it doesn't really cause a deviation because of growth arrest. There may be a little, but it doesn't cause much of a problem. I'm not saying it doesn't cause, but compared to a proximal humerus fascial arrest, a distal humeral fascial arrest causes less problems of growth. There are no problems of stability and non-injury. All right, so I think I'll start the next talk about fascial arrest. Yeah, can you see the screen?
Yeah.
Yes. Yes.
Okay, good. Okay, so let's talk about fascial arrest now a little bit. And okay. All right. Okay, so you can see this, right?
Yes, sir.
You,
Yeah,
you
Yeah,
can
we
sir.
see and hear. Shall I go ahead?
Yeah.
Okay, okay. Chalo. Okay. So we talked about anatomy of the physis. This is again to just remind you from where growth happens and where does blood supply come from. Okay, so the basal layer is towards the cartilage of the articular side. Okay, this is where the resting cells are. Then they mature, then they get early ossification, and then they are forming metaphyseal bone or remodeling in the metaphyseal area where you have the hairpin loops of vascularity where osteomyelitis starts. Also, from the metaphyseal area, you have one perichondrial vessel, which is the perichondrial ring, or also called as zone of Ranvier, where the bone becomes wider transversely. Okay, and the rest of the bone becomes long in the epiphysis. Okay, this is how it is. So, which of these are going to cause growth arrest? So, first thing you need to know is which of these cause growth arrest. All right, I told you which injuries cause growth arrest. Type 3. Type 3 is going through resting cartilage, epiphyseal blood supply, and the ossifying cartilage. It's also intraarticular and it is transphyseal. This can cause growth arrest. Type 4, obviously, because of displacement and loss of blood supply from both sides, as well as resting cartilage. Peterson 1, where you have crush. So, any kind of crushing, you must suspect that this may have growth arrest. Type 6, obvious, half the physis is missing, you will get a growth arrest. And the rank types, that is perichondrial or avulsion type fractures. Okay, peripheral injuries. So when you get a growth arrest, what happens and what are the types? So the growth arrest can be either a complete arrest or a partial arrest. And the partial arrest can be central, peripheral, or a mixture, a combined arrest. In the older days, people used to do what is called as tomograms. Today we have CT and MRI. Okay, a tomogram used to be a cross-sectional sort of like a CT, where you used to get multiple views and then you could collate them and try to find out what is the nature of the growth arrest. So these were few images. These are historic images from Bright's paper and Peterson's work, where he described a peripheral bar, a central anteroposterior bar, or a central focal bar. Okay, so these are some old kind of injuries. So we should understand what physeal bar causes what kind of problem, and then we can make some plan as to how we are going to treat a physeal arrest. So remember that any bar which is in the periphery is going to cause coronal plane deviation. Okay, if it is in the sagittal plane periphery, it will cause a sagittal plane deviation, and I'll show you examples of both. If you have a central bar, it will cause change in the articular alignment because of tenting. And if you have a complete arrest or a patchy or a mixed kind of arrest, then you will get a lot of shortening. And also, you may get angular deformities depending on what is happening. So the early sign of a growth arrest is a Harris growth arrest line. And I have already spoken about it earlier. You will see a density line, which as long as it runs parallel to the physeal plate, you have had a temporary growth arrest, it has resumed growth, and there is no focal spot weld or a physeal arrest across the physis, and the growth has resumed as long as it's parallel. Okay, so these were the Carlson and Wenger bar maps depending on tomograms. Okay, again, historic. Today, the gold standard of defining a physeal bar is an MRI. And you must ask your MRI person to tell you where the bar is. You must quantify the bar. Is it central? Is it peripheral? How far is it from the surface? And what is the width of the bar? What is the AP dimension? What is the lateral dimension? So that when you're trying to resect a bar, you know from where to approach it. So you can see this is how a bar looks like. You have white, bright signals of a cartilage. You have a white, bright signal of articular cartilage. And at one point, you have bone formation, which is a black spot going from epiphysis to metaphysis. So this is a posterior peripheral fascial bar. Okay. What are the treatment determinants? The treatment of fascial bar depends on the age, the bone involved, the location, the amount of bar formation, and what caused the bar formation. So older the age, the better, because the amount of deformation that will happen is lesser. So the time to fusion is less. Which bone is involved? Lower femur has the highest rate of growth, 9 millimeters per year. So it is worse if the child is younger with a lower femoral arrest. Where is the location of the bar? A central bar which is localized is easier to resect. How much of bar has formed? Less than 50% is better for resection. Ideally 30% or lesser. If it is larger, we have more problems. And the nature of the growth arrest. If it is a post-traumatic bar, it's more amenable to resection compared to a bar formed by radiation injury, vascular insult, or infection. You can have a growth arrest because of infection also, and those bars can behave unpredictably. Trauma is more predictable. What are your options? If you have a patchy bar, your option is to complete the growth arrest so that there is no angular deformity and you have pure shortening which can be lengthened later. Or you have an option of doing osteotomy. You do osteotomy away from the fascial plate. You know that it will recur and then you have to repeat osteotomy. So you may have to do multiple operations. Third, you do a bar resection and try to restore growth. By removing the bar, restoring growth in the remaining bar, getting rid of the tenting, and then putting an inert material to prevent reformation of the bar. The fourth is when you have a pure growth arrest, you do lengthening. And finally, most of the times you will have to do a judicious combination of all of the above. So let's come to some cases so that you get an idea of how I have treated these bars and some philosophy. So this, you can see this is a young child who had a injury to the outer aspect of the ankle. And you can see that there is a diffuse peripheral bar here. The ankle is overgrowing medially. A large amount of growth is remaining. Fibula has undergone a complete growth arrest, and lateral physis of the tibia also is not healthy, whereas the medial physis looks healthy, and this is going to a further deformation. So MRI will show you that this is a patchy damage. It's not a focal bar which can be resected. So now I have to analyze what can I do for this child. Now, distal tibia again contributes to about 60% of growth of the length of the tibia, and this is going to cause further deformation because the medial side is open. I cannot resect this bar and the child has a lot of growth remaining. So what can I do? I can convert this to a complete fasciodesis. And how do I plan for that? I did a corrective osteotomy with the apex at the healthy cartilage. So I did a very low osteotomy rather than doing a metaphyseal osteotomy. And I resected the complete healthy part of the physis also. And I did a tension bind and I compressed it because I wanted to create a complete growth arrest. So I got two things in one surgery. I got deformity correction and I got complete epiphysiodesis. And now the child will have pure shortening, which I will compensate with a shoe raise. And at appropriate age, I will do lengthening depending on the rate of shortening after it exceeds about 2 inches. Till then, I will give a corrective shoes. But I have stopped and prevented further deformation of the bone. This is another example, a Peterson 6 injury, a runover injury of the foot and ankle, tire going over the leg with a missing lateral physis, missing soft tissue. Again, there was a skin graft here, and you can see the medial physis overgrowing. So this was the X-ray, this was the picture, and the child is older. He was about 12, 13 years. So what we did here was we resected a little part of the fibula. I did a medial epiphysiodesis with a low osteotomy going through the physis. And with an external fixator, the chest fixator, we distracted and corrected the deformity and stretched the skin graft. And that is the deformity correction. So we got a plantigrade foot, the scar got stretched out, and the child was able to walk with a plantigrade foot with a complete epiphyseal disease on the medial side in a couple of years. Okay, the prominence on the medial side remained because of the long duration. If you want, we can shave this off for cosmetic reasons, but this had stopped growing and the foot remained plantigrade and nice for the child to walk on. Now this 17-year-old child, now this was an adult, near adult. He had suffered a growth arrest as a child and developed an ulnar overgrowth and a manus valgus deformity. This was his X-ray picture. A distal radial growth arrest. Now what can be offered for this? I cannot restore growth. He's already mature. Ulna has nearly stopped growing. But the ulna has grown so far ahead that it is causing deviation and the radius is short. So I need to balance this out. I did not want to do too much of a lengthening because the difference was quite a lot. So I did a compromise. What we did was ulna shortening. I resected about 1.5 centimeters of the ulna, shortened the ulna, and then I did a monolateral fixator and I lengthened the radius. So you can see over a period of time, the gap increasing here, ulna acute shortening and radius distraction osteogenesis. And then this is the healing. And I brought the radius to the level of the ulna. So I did a compromise, a little bit on this side, a little bit on that side. And he was skeletally mature. And this is how he healed finally. This was his cosmetic correction. And this was his functional correction. He had very good range of motion and his activities of daily living were restored without a problem. So this is a pretty old case, about 10-15 years ago. And this was how we restored his
Fantastic.
function.
Very
So
nice.
the next case is a physeal bar excision. So how do you excise a bar, right? So you have to map the bar, you have to excise the bar, and you have to interpose something to prevent reformation. So this is an example where I have again demonstrated that this child, you see, had a femoral fracture. Now the treating surgeon treated him conservatively in a Thomas splint. Okay, fair enough. No problem. It healed very well. But he started developing a flexion deformity in the knee. Initially, the surgeon thought that it is because of his immobilization. But if you see very closely, he also had a posterior physeal injury. And this was the MRI of the same patient. He had a posterior physeal bar. So what was happening is anterior overgrowth. Anterior femur was growing, posterior femur had stopped growing, and he was developing a procurvatum deformity in the distal femur. And he had some growth remaining. So we mapped the bar. We found out how far away it is from the surface landmarks, medial, lateral. So that was the MRI. Second was the approach. So to approach a central bar, what you can do is take a metaphyseal window and then make your burr or your drill go into the center to resect this. So this is called Jackson's modification. You can pre-drill a screw so that when you put the piece back, you know where to put the screw. So you pre-drill, pre-tap and take out a triangle and then from within here approach the physeal bar. So this is the approach with a metaphyseal window. For a peripheral bar, you can have a direct approach and just resect, always resect more than what is required. Okay, so that it doesn't reform. And always take out more, 2 mm more on either side, and then you pack in some inert material there. Third step is visualization. How do you know you have resected the bar adequately? Now for this, you can have two things. One is a direct visualization. Sometimes you can use small dental mirrors, which are at an angle. So that dental mirror can allow you to see around the physis after your resection is over and use a burr so that you clear the area and you see white shiny cartilage all around. Okay, I have plenty of photos, but it is difficult to get visualization. So what my suggestion is, you can use a small arthroscope to put it there and see on the TV to see the bright white or bluish cartilage all around. Or you can use a CM with a dental mirror, or you can use an arthroscopy light source, a fiber optic cable light source to put into that small tunnel that you have made so that you can visualize that and make sure that you have resected it. So this is the window that we made. It was a posterior and lateral bar which was there. So we used curettes and burr And in that small hole that we created under C-arm and with an arthroscopy light, I removed that bar posteriorly and then we packed in interposition material using fat graft. So what are the various things that have been used? People have used cranioplast, which is used by neurosurgeons or dentists. You can use adipose tissue. Somehow research has shown that gluteal fat has got some chemical properties which prevents bone formation. So what is recommended is either back of the thigh or buttock area, get some fat from there and put it in that defect. And I always take a vicryl stitch because these surgeries are done under tourniquet. When you release the tourniquet, you can have bleeding and the fat may just flow off. So I secure that with a vicryl transosseous stitch so that the fat remains there. Okay, and then the enzymatic, whatever chemical is there in it, prevents bone formation across the epiphysis to metaphysis. People have tried putting cartilage from the iliac crest to restore growth. It is purely experimental. There is no evidence that it works. And sometimes it has worked haywire. It grows into, people have demonstrated in goat and sheep models that they have created osteochondromas or sometimes chondrosarcoma. You can have bizarre growth. So we don't know whether that is useful. Again, people have tried stem cells, vascularized fascial transfers, but on a routine basis, we use either fat graft or we use bone cement. Bone cement can also be used as an inert material. Okay, and my common choice, cheap choice is fat. Finally, you can put markers. People have used small 1 mm K wires and cut them flush so that if there is restoration of growth, you see that they separate. And as it grows, they will move apart. So you know that growth has resumed. So they are like surrogate markers of your Harris line, metallic markers. Okay. So this 9-year-old, we did that surgery and we stopped that procurvatum from happening. So this is the quantum of resection and the fat graft which was put in that area. And this is a 7-year follow-up where the deformity has pretty much straightened out and he has full range of motion. And that fortunately did not recur and I did not need to do any lengthening or osteotomy and he just healed well. Another example, a very young girl who had a Salter 2 injury to the distal tibial metaphysis. Okay, and this was treated in a plaster. They thought it's just a metaphyseal fracture. But after a couple of years, they started noticing a progressive varus deformity. Fibula was overgrowing and the tibia was showing tenting. And there was a fascial arrest with tenting of the intra-articular component. You can see that joint line starts getting tented. This is after 1 year. So the joint line was getting deviated and the child was just 2-3 years old and long growth was remaining. She was the niece of one of the orthopedic surgeons around Pune. And we localized that fascial bar using again MRI and mapping. And then CT, MRI both. We went and what I did here was, this was the deformity in that girl. This is, you can see 2007. Okay, long time ago really. So what I did was I did a metaphyseal osteotomy. I went in through the same area. Okay, and then you can see I have removed the fascial bar, that roof which was tenting using burrs. So that is what we did. And then I opened that and I did a fibular osteotomy and did a correction from the same level. So we approached from there, we put the fat graft there and I used a mini fixator. Again, the child was so small, I didn't have a suitable implant. So I just used a Jess fixator and I put a small mini fixator. This is the acute deformity correction, small drain kept there. This is a 5-year follow-up of this child after the fascial bar resection and restoration of growth. And this was pretty good. This was the child's picture, clinical picture, and this was the child's function. Child sent me the videos 5 years after the surgery, running, jumping, hopping, doing everything. And about 2 to 3 years ago, I asked for more videos. She's now 12 years old. And I'll go back. So at 12 years also, she's maintained her correction. Okay, this is the side we operated, the right leg. And now she was, I think, 10th standard or something and doing quite well. Not much of a problem. functionally completely all right, and jumping, running, doing all activity. So local bars, fascial bars, where a lot of growth is remaining, you can definitely do this fascial bar resection and fat grafting procedure. This is another example where there is a central bar and there is a lot of tenting. You can see what happens with a central bar. It doesn't cause angular deformity. The alignment looks pretty okay, but the joint line has gone completely haywire. Okay, so this may cause further issues. Fibula is overgrowing again. So what I did was I resected the fibula. You can see the fibula is taken out, and we went in from the metaphyseal region and resected this area. And I did a growth modulation for the distal femur. Okay, because this was going into valgus, I stopped growth here, and we got a decent control. This was a 14-month follow-up, and child was doing quite well at last follow-up. So this was an intra-articular open surgery and quite a large surgery. Now this example I have shown you earlier in the lower radius fracture talk. Comminuted Salter 2 injury, 3 late manipulation, open reduction, ended up with growth arrest, and then we tried to resect that. Mapping was done. We removed the fascial bars, put the markers, epiphysiodes the ulna, but it did not work. So sometimes, especially lower radius, literature has shown that fascial bar resection may not be predictable. And at maturity, when it was a failed bar resection, I did a lengthening conventional, and we took out that screw and gave him a well-balanced wrist. This was after lengthening, and everything was done. Now the same kind of a injury in a 15-year-old. See, now at 15, the growth remaining is very minimal. Okay, so what I can do is I can do acute correction and just resect the distal ulna. Okay, so I did a 1 centimeter shortening of ulna. I put a screw across the physis so that there is no more growth here. And I did a angulation, distraction, acute correction, and I put the same graft from here into this area. So 1-step surgery, plaster, that is how it healed with epiphysiodesis, and that is his function. So older children, you can offer acute correction with epiphysiodesis. Now this 11-year-old boy, this is interesting. This is an injury by a cricket ball. He had a blunt season ball injury to the upper tibia and came with a deformity. He had a progressive varus deformity. And after we did an MRI, this was a Rang type of an injury. Yeah, perichondrial injury, which has caused a growth arrest, which is on the periphery. And the lateral continued to grow and medial stopped growing. Okay, this is the MRI showing the perichondrial injury. This was the deviation. So what we planned was we resected that fascial bar. Okay, that restored the growth by detethering, and we did a growth modulation on the opposite side. And this is a cement spacer. Okay, this was bone cement and a growth modulation. And over the years, slow correction, lateral hemiepiphysiodesis, 6 months post-op, not much correction, but 12 months post-op, you can see decent correction, and 18 months post-op, you can see the cement has also moved away, growth has restored, and the alignment is pretty good. And then that was a longer follow-up where you can see the markers also growing away from each other. And then we removed the growth modulation device. An 8-year-old fracture femur, elastic nailing was done. You can see here the lateral nail is very close to the physis and is lying on the growth plate. Not a very good thing to do. Nails were removed after 9 months, progressive valgus. Peripheral tether here. You can see on MRI, peripheral growth arrest. Rest 70% of the physis is intact. More focal growth arrest. Go ahead and resect it, localize it, use a burr and growth modulation on the opposite side. In 6 months' time, some correction, and over a period of 1 year, complete correction, and then restoration of growth. So peripheral bars, localized bars will really do well if they are adequately treated. So take-home message is that you must diagnose the bar early. You must monitor for a few months or a year what is the effect it is having. Is it coronal? Is it sagittal? Is it growth retardation? Is it tenting? Is it change in the articular alignment? get an MRI, map it adequately, plan the appropriate correction. It could be a combination. There is a learning curve. It doesn't work all the time. You must have the appropriate tools to do it and some experience, and always keep a long follow-up till maturity. So the more you see, the better you learn. We do iFix every year. Attend it whenever possible. Next year, iFix is in August at Ganga Hospital, operative course. So we'll talk more then. So thank you very much for your attention, and we'll answer a few questions.
May I?
Yes, sir.
Uh, is the role of MRI better than CT scan in diagnosing and managing the facial bar?
So, sir, because it's a cartilage injury and MRI is always better to diagnose it, but a mapping will need a combination of both.
Okay.
Because it's ultimately bone. It's a bone bridge from epiphysis to metaphysis. So definition of that bone is always better on a CT. So today's world, no, when we are planning such a delicate as well as a complicated operation, if you have all imaging modalities, there is no point in doing only one. Diagnosis is better with MRI, but planning can be better with a CT.
Right. Thank you.
Yes, Gopendra. Gopendra, I think you have raised your hand, or it's from previous talk. It's still not put down.
Sir, which type
Yes.
of burr can you specify you use for bar excision?
Dental burrs, you have orthopedic burrs also. We have good burrs because we have an oncosurgeon who does a lot of giant cell tumor curettage. So you get very small 2 millimeter, 3 millimeter, 4 millimeter burrs. They are very good sharp burrs, low speed. You can control the speed of the burr. Continuous irrigation and gently keep on burring till you see white cartilage all around. And if you don't see it, you flush it, there'll be some bleeding. So flush it with water, use a arthroscopy light source, and or you can just put a scope and you'll see it on TV. If you see nice white shiny cartilage all around, your bar has completely gone away. And like I said, no, if you don't have all these tools, cut a little more, okay, rather than undercutting, overcut. Ultimately, growth happens from the periphery where the remaining healthy cartilage is there. Purpose of bar excision is to take away the tethering and replace it with an inert material so that again tethering doesn't happen by another bar.
Okay. Yes, sir. And what do you prefer, bone cement or fat interposition?
I have used both.
Your personal.
Results are equally good. There is a small theoretical disadvantage that the heat of the bone cement, sometimes people say, may cause further necrosis of the cells. But ऐसा ज़्यादा कुछ होता नहीं है. Cement is more better seen on X-ray. You can see क्या होता है, cement costly है, fat cheap है, free है. Secondly, fat has got a better way of preventing reformation. And sometimes cement in the later age, it's a foreign material. You may have to remove it. It can get infected. So, yeah. So very small amount of cement is not available. You have to open a 20-gram packet and insert it. I've used both. Both can work. It's not a problem, depending on whatever you want. Fat, as I said, can flow off. So that entire fat chunk that you take it with a little fascia, pack it in, and then take a vicryl stitch through bone to hold it there, so that it doesn't really flow off.
Yes. Thank you, sir.
Okay. All right. Any more questions, or we'll have dinner?
Good evening, sir.
Yes.
Good evening.
Sir, in the pediatric age group for proximal phalanx type 2 basal injuries, how can you treat, sir? Particularly in the second finger and fifth finger.
No, see, hand injuries, the principles of rotation apply equally well. In a child, healing is much better and remodeling is excellent. So Salter 2 injury, make sure that there is no rotational malalignment. So give anesthesia, correct the deformity, and you can splint it with the next finger with buddy taping. I am not very fond of putting screws or anything in children at all. If you want, you can put a temporary K-wire. That also is not required many a times. It will remodel.
Thank you, sir.
Sanjeev Kumar.
Sir, myself just now asked that question.
Acha, you asked it. iPhone कौन है अभी?
Yeah, hi sir. Pradeep here, sir. Sir,
Pradeep,
showed one case like a digital femur. They put tens nail, and the
Yeah.
entry was not through physis, but the tens nail was over the physis.
Sitting on the physis. Yeah,
Yes,
you can get a
that-
peripheral injury to the perichondrium, which is why in
Okay.
my 10 commandments I told you 2 finger breadths above the physis.
Okay.
Don't go very close to the physis and don't let the tip of the nail sit on the physis. It can
Okay.
cause a peripheral teether and a bar.
Okay. Oh, because the
That's an
distal-
iatrogenic type 6 injury.
Yes, sir. Okay, sir. Thank you.
Sir, if any IM nails is passed through piriformis and the growth
Yeah.
arrest happens, how to treat it, sir?
You have to treat the consequence. I showed you one case where through the physis, if it has gone, and you will either get coxa vara or coxa valga. You will have to do appropriate treatment with an varus or valgus osteotomy and epiphysiodesis if it is still growing. So 2 risks of going through that area is one, if you are through piriformis, you can hit the lateral ascending epiphyseal vessel, get AVN. And second is a deviation in the neck shaft angle, excessive anteversion, retroversion, or varus or valgus. So you quantify what is the problem and treat accordingly. All right.
There's just one question.
Yes, Rohit.
In between acute correction and slow growth modulation, how will you decide which one in which case? I mean, you have shown both actually.
Yeah.
In ankle, you showed acute deformity correction, osteotomy, and fascial bar resection, and in the femur,
No.
you showed growth modulation as well as fascial bar resection.
Correct. But Rohit, the difference between two was, one was a non-resectable bar. If you saw in the ankle, I did not resect the bar. I removed the healthy cartilage and created epiphysiodesis.
Okay.
Whereas in the femur, I resected the focal bar to restore growth.
Okay.
That was the difference.
So how much growth?
So when I want to cause complete epiphysiodesis,
okay,
I will go with an osteotomy and close the physis going transphysial to damage everything there.
Okay.
Because I want a sound complete epiphysiodesis which will cause only length issue. No more coronal deviation. See, you saw in distal ulna, a percutaneous screw trying to stop growth arrest doesn't work. You have to damage it physically.
Yes.
If you want to create epiphysiodesis, no, the old way of Femister, cut through the epiphysis works the best. Percutaneous screws and all. When you don't want a complete epiphysiodesis, you want partial reversible epiphysiodesis, then you can go for PET screw, percutaneous, or a 8-plate, where you want slow growth correction and you have resected opposite side bar. So you have taken away the teether and you have slowed down growth and allowed the slowly growing physis to catch up. So you must have growth remaining. If it's towards maturity, 15-year-old, then I will not do, I will do acute correction. So that's what I said. It's a balance. It's a very fine balance between what physis are you dealing with, how much is the injury, what is the age of the child, is it a fast growing physis, and what are you trying to achieve out of it. And then with experience, you will come to a plan. Okay.
Sir, one question. For genuine deformity, in 12-year-old girl, what would you prefer? 8-plate or PET screw?
No, my choice is, see, I don't like to use, see, if you look at literature, both have equal results. They have just reported that the nature of complication may be different. But they are saying a PET screw works as well as a 8 plate. But the problem with the percutaneous PET screw is the trajectory of the screw to get it directly into the center, because you have to go really high up on the diaphysis. So passing the screw in the center on the half side of the condyle is a little tricky unless you have good experience. Secondly, I don't like putting a threaded implant across the physis, which may sometimes cause a complete arrest. Whereas a peripheral teether like an 8 plate is reversible. When I remove that plate, the growth will resume. So my choice is always 8 plate. I don't do PET screws very often.
But it's a 12-year old girl. So the correction correction chances is very less.
No. That is, see, you are asking two different questions. Your first question was, which is better, 8 plate or PET screw?
No,
The answer to that was
sir.
both work equally well. My choice is 8 plate.
Yes, sir.
Your second question is, at 12 year, will hemiepiphysiodesis work?
Yes.
For that, you must do what is known as the elbow X-ray, draw the growth curve, find out the bone age, find out whether she has started her periods, whether she has achieved menarche. If you find that she has already achieved menarche 1 year ago, elbow olecranon on epiphysis is already partially fused, then growth modulation as a method is not going to work. Especially if the intermalleolar distance is more than 15-17 centimeters. Then it is better to do osteotomy after growth is finished after 1 more year. Otherwise, you will get undercorrection or your growth modulation won't work. Whatever way you may use it, 8 plate or PET screw. So that is a different decision making. Don't confuse the two.
Yes. Thank you.
Yeah. All right. Okay. So I think we'll end today's session and we'll do the next session next time, fracture neck femur and Monteggia fracture dislocation.
Sure, sir.
All right. Chalo. Good night.
Good night, sir. Good night.
Thank
Thank you very much, sir. Good night.
Good night. Good night, everyone.